Acute liver failure is one of the few conditions where a previously healthy person can die within days, and where the single most important thing you do is recognize it early enough to move them. Everything else follows from that. The definition is precise, the causes are a short list, and the management is largely about protecting the brain and finding out whether this patient needs a new liver. We will follow one patient the whole way through. Here's our patient, a 31-year-old woman, 3 weeks of feeling generally unwell. Then jaundice about a week ago. Her family brought her in today because she has become drowsy and muddled. She has no previous liver disease. She does not drink. And there has been no paracetamol overdose. The one thing in her history, isoniazid, started 2 months ago for latent tuberculosis. Hold on to that. We will come back to it. 10 objectives. The definition and its exceptions. The vocabulary of timing. The causes. Grading encephalopathy, why the brain swells, the workup, the management of the 3 things that kill these patients, the King's College criteria, and the mortality figures that explain why all of this has to happen quickly. The definition has 3 parts, and you need all of them. An acute liver injury of less than 26 weeks, plus coagulopathy, plus encephalopathy, and it must be occurring without pre-existing liver disease. The encephalopathy is the piece that matters most. A patient with a huge aminotransferase and a raised international normalized ratio who is fully alert has acute liver injury. Add confusion and it becomes acute liver failure. A different disease with a different urgency. 3 diseases are exceptions to the no pre-existing liver disease rule. Autoimmune hepatitis, Budd-Chiari syndrome, and Wilson disease. All 3 are labeled acute liver failure even when there is already chronic liver disease. The reason is practical rather than academic. All 3 can decompensate catastrophically, and all 3 have specific treatments. Excluding them on a technicality would delay exactly the patients who most need moving to a transplant center. 3 terms you will hear used interchangeably and should not. Fulminant means encephalopathy within 8 weeks of the onset of jaundice. Subfulminant means encephalopathy between 8 and 26 weeks. Same disease, slower course. Acute-on-chronic liver failure is different altogether. That is an acute insult landing on a liver that is already chronically diseased. Different population, different prognosis, and in most systems, a different transplant pathway. Now the causes. And this is one of those lists where the first line does most of the work. If you remember nothing else from this section, remember that the great majority of acute liver failure in the United States is caused by something the patient swallowed. Nearly 80% of acute liver failure in the United States is drugs or toxins. And acetaminophen alone accounts for more than 40% of all cases. That is the single commonest cause by a wide margin, which tells you where to start in every patient, an acetaminophen level, and a proper medication history that includes over-the-counter drugs, herbal preparations, and anything a friend or relative supplied, not just the prescription list. Drug injury comes in 2 flavors, and they behave completely differently. Dose-dependent injury is acetaminophen, predictable. The injury follows the dose, which is why a level and a nomogram are useful. Idiosyncratic injury is not related to dose at all. It appears weeks to months into a course of a drug the patient has been tolerating. There is no level to send and no nomogram to plot. The medication history is the entire diagnostic test. 4 groups worth memorizing. The anti-tuberculous drugs. Isoniazid, rifampin, and pyrazinamide. The anti-epileptics, phenytoin, valproate, and carbamazepine. The antimicrobials and the non-steroidals, fluoroquinolones, macrolides, and nitrofurantoin, and then amiodarone and the tricyclic antidepressants. Note how many of these are drugs that get started and then quietly continued for months, which is exactly the window in which idiosyncratic injury appears. And then the things that never appear on a medication list. MDMA and cocaine can both cause acute liver failure. Certain herbal preparations are a recognized cause. And then there is Amanita phalloides, the death cap mushroom. In the United States, that ESA West Coast exposure. The practical lesson is about how you take the history. Ask what else they took, not what was prescribed. Supplements, protein powders, herbal teas, and in an unexplained case, foraged mushrooms. There are 2 viral lists, and which one you use depends on the host. In an immunocompetent patient, hepatitis A, hepatitis B, hepatitis C, rarely, hepatitis D alongside hepatitis B, and hepatitis E, which is particularly dangerous in pregnancy. In an immunosuppressed patient, the list changes entirely. herpes simplex. And note that only half of those patients have skin lesions. Epstein-Barr, varicella zoster, cytomegalovirus, and human herpesvirus 6. The rest of the list. Vascular causes are Budd-Chiari syndrome, ischemic hepatitis, and hepatic sinusoidal obstruction syndrome. Then the others. Wilson disease, pregnancy-related liver failure, which covers acute fatty liver of pregnancy, preeclampsia, and HELP syndrome, the first presentation of autoimmune hepatitis, and a genuinely idiopathic group. In a woman of childbearing age, a pregnancy test is part of the workup for exactly this reason. Her history fits idiosyncratic isoniazid injury. Onset 2 months into therapy, dose irrelevant, but fitting is not the same as proven. So you still send an acetaminophen level regardless of the history. Viral serologies, a pregnancy test, and autoimmune and Wilson studies. And note the timing. Encephalopathy 1 week after the onset of jaundice. That is fulminant liver failure. And critically, it is the non-acetaminophen kind, which changes both her prognosis and her transplant criteria. Acute liver failure is not a liver problem with systemic consequences. It is a multi-organ illness from the beginning. The presentation is often deceptively mild: nausea, vomiting, right upper quadrant pain, poor attention, disordered sleep. And then it accelerates. We will go system by system, because each one carries a management decision. Grade the encephalopathy every time you see the patient. Grade 1 is an attention deficit, subtle, and easily missed. Grade 2 is asterixis with altered mental status. That is the threshold at which acute liver injury becomes acute liver failure. Grade 3 is somnolence and rigidity. Grade 4 is coma. And grades 3 and 4 carry 2 specific actions. Intubate the patient, and consider intracranial pressure monitoring. The grade is not a description. It is a trigger. Follow the mechanism. The failing liver stops clearing ammonia. Arterial ammonia rises, astrocytes swell, and cerebral edema in acute liver failure is driven in part by that rise. Inside a rigid skull, swelling becomes pressure. And when intracranial pressure climbs high enough, you get the Cushing reflex. Bradycardia with hypertension. That is a late sign and an ominous one. The goal of everything we do for the brain is to never see it. The circulation fails in a specific way. Hypotension with a low systemic vascular resistance. A distributive vasodilated shock that looks physiologically like sepsis. Which is one reason infection is so easy to miss here. On the pulmonary side, a respiratory alkalosis early, impaired peripheral oxygen uptake, pulmonary edema, and in the sickest patients, the acute respiratory distress syndrome. These patients need an intensive care unit, not a ward bed. Gastrointestinal bleeding is common enough that proton pump inhibitor prophylaxis is routine, and pancreatitis occurs from ischemia, from the drug, or from infection. On the renal side, you can get acute tubular necrosis or hepatorenal syndrome, plus a characteristic set of electrolyte problems: low sodium, low potassium, and low phosphate. The phosphate one is worth knowing. It is easy to overlook, and it worsens both weakness and mental status. The coagulopathy here is more interesting than it first appears. Yes, there is thrombocytopenia, a prolonged prothrombin time, and a low fibrinogen. The liver has stopped making clotting factors, but it has also stopped making protein C and protein S, which are anticoagulants. So the deficits partially balance. Bleeding when it happens is mostly driven by low platelets and by disseminated intravascular coagulation, which gives you an important rule. A high international normalized ratio here is a prognostic marker, not automatically a bleeding risk. Infection is the complication that catches teams out. The organisms are staphylococci, streptococci, gram-negative rods, and fungi, driven by impaired immune function and by every invasive line and procedure. And here is the problem. Fever may be absent, the white count may be absent, and the patient's shock already looks septic because of the vasodilation. The commonest sites are respiratory, urinary, and the bloodstream. Assume infection is possible at every deterioration. And the metabolic consequences. Hypoglycemia, because the failing liver cannot synthesize glucose. A metabolic acidosis with a raised lactate. And adrenal insufficiency, which is easily missed. The clinically vital point is the first one. Hypoglycemia looks exactly like worsening encephalopathy, so every time the mental status drops, check a glucose before you conclude the brain is swelling. It is the one reversible cause you can fix in 60 seconds. The workup has two layers: a broad first-line panel that everybody gets, and a targeted second layer driven by what you suspect. The reason for the broad panel is that specific treatments exist for several causes, and the earlier you identify them, the better they work. Everybody gets 3 sets of tests: hematology and coagulation, a full blood count with a prothrombin time and a partial thromboplastin time, chemistry, liver tests, electrolytes, urea and creatinine, and ammonia, APH, and arterial lactate, and amylase and lipase, and the cause-finding tests, an acetaminophen level in every patient regardless of the history, viral serologies, and a human immunodeficiency virus test. Then the targeted studies: autoimmune hepatitis serologies with an immunoglobulin G level, ceruloplasmin with serum and urine copper for Wilson disease, and a pregnancy test in any woman of childbearing age. That last one is not a formality. If this is acute fatty liver of pregnancy, preeclampsia, or HELP syndrome, then delivery of the child is the treatment, which makes the pregnancy test one of the most consequential tests on the list. Beyond the blood tests, image the liver, a right upper quadrant ultrasound, or an abdominal computed tomogram, and, critically, Doppler studies of the portal and hepatic veins. You are looking specifically for vascular occlusion, because Budd-Chiari has a treatment, and biopsy, only if the cause remains elusive after initial testing. Given the coagulopathy, it is usually done transjugularly. It is not a first-line test, and it should not delay transfer. Management divides into where the patient is cared for, support of the failing organs, and treatment of the specific cause. And the first of those 3 is the one most often got wrong. So we start there. The first decision is where this patient is managed. And the answer is an intensive care unit at a liver transplant center. They need hemodynamic and ventilatory support, continuous veno-venous hemofiltration if there is acute kidney injury, and early listing for transplantation in selected patients. The mistake is waiting to see how they do. By the time a patient reaches grade 3 encephalopathy, transfer is far more dangerous and the window may have closed. Protecting the brain. Consider intracranial pressure monitoring at grade 3 or 4 encephalopathy. If the pressure rises, mannitol at 0.5 to 1 mg per kilogram. Give prophylactic 3% saline if the arterial ammonia is above 150, or if there is grade 3 or 4 encephalopathy. Acute kidney injury, or the patient is on vasopressors. Target a sodium of 145 to 155. And for refractory pressure, barbiturates and hypothermia. 2 rules that surprise people. First, intubate for grade 3 or grade 4 encephalopathy, both for airway protection and for control of carbon dioxide. Second, and this is the one that catches trainees, lactulose is of little benefit in acute liver failure and may actually be detrimental. That is the opposite of what you do in a cirrhotic patient with hepatic encephalopathy. Acute liver failure and decompensated cirrhosis are different diseases, and they are managed differently. 2 more support decisions. For the coagulopathy, give vitamin K, but give fresh frozen plasma, platelets, or cryoprecipitate only if there is active bleeding. Blind correction risks volume overload, and it removes the very marker you are using to judge prognosis. For infection, have a low threshold for broad-spectrum antibiotics. Vancomycin with a 3rd-generation cephalosporin is a reasonable starting point, and add antifungal cover in high-risk patients, those on parenteral nutrition or hemofiltration. Where a specific treatment exists, use it. Acetaminophen gets N-Acetylcysteine. Hepatitis B gets antiviral therapy. Wilson disease gets plasma exchange as a temporizing measure while transplant is arranged. Herpes simplex gets intravenous acyclovir. Amanita phalloides gets penicillin G. Pregnancy-related failure is treated by delivering the child. And Budd-Chiari gets anticoagulation and a transjugular intrahepatic portosystemic shunt. For autoimmune liver failure, the data on steroids are lacking, but they are often given. One drug deserves its own slide. N-acetylcysteine improves survival in non-acetaminophen acute liver failure, not just in poisoning, which means it is given regardless of whether acetaminophen is implicated. It is safe, cheap, and available in every hospital. In practice, you start it while the cause is still being worked up. Our patient has isoniazid injury. She has never taken an overdose of anything, and she still gets N-acetylcysteine. And now the decision the whole admission is built around: which patients will not survive without a transplant? The King's College criteria are the tool we use to answer that. And they have 2 separate arms. Because acetaminophen liver failure and everything else behave differently. The acetaminophen arm is the simpler of the two. Either an arterial pH below 7.3 on its own, or all three of the following together. Grade 3 or 4, encephalopathy. An international normalized ratio above 6.5, and a creatinine above 3.4. Note that a single blood gas can meet the criteria by itself, which is why an arterial pH belongs in the first set of tests on any acetaminophen patient. The non-acetaminophen arm. A prothrombin time above 100 seconds meets the criteria on its own. Otherwise you need any 3 of 5. Age under 10 or over 40. Jaundice for more than 7 days before the encephalopathy started. A prothrombin time above 50 seconds or an international normalized ratio above 3.5. A total bilirubin above 18. And an unfavorable cause, which means viral hepatitis, drug-induced injury, Wilson disease, or a low factor V level. And here's why the cause matters so much. Non-acetaminophen acute liver failure carries a mortality of about 70%. Acetaminophen-induced failure, 25 to 30%. A little over a third as high. The reason is that a liver can regenerate after a single toxic hit that has passed. It does far worse when the insult is ongoing, which is the situation in viral, autoimmune, and idiosyncratic drug injury. Certain causes predict a worse outcome. Hepatitis B, Wilson disease, autoimmune hepatitis, drug-induced injury, and Budd-Chiari. And there is one laboratory value worth knowing separately. A factor V level below 20% in a patient under 30, or below 30% in a patient over 30. Both are associated with a poor prognosis. Factor V is short-lived and made only by the liver, so it tracks synthetic function very closely. Back to our patient. The isoniazid was stopped immediately. She was moved to intensive care at a transplant center. N-Acetylcysteine was started on arrival, even though this is not acetaminophen, and the full cause-finding panel went off. She met 3 of the 5 non-acetaminophen criteria. Jaundice for 7 days before the encephalopathy, an international normalized ratio of 4.1, and an unfavorable cause. She was listed on day 1 and transplanted on day 4. 7 ways this goes wrong. Missing the encephalopathy and calling it acute liver injury. Not sending an acetaminophen level because the history says there was no overdose. Transfusing plasma to correct a number in a patient who is not bleeding. Giving lactulose the way you would in cirrhosis. Assuming that no fever means no infection. Blaming a drop in mental status on the brain before checking a glucose. And the biggest one, waiting to see how they do before calling the transplant center. 6 things to carry with you. 1. Injury under 26 weeks. Plus coagulopathy. Plus encephalopathy. All 3. 2. Autoimmune hepatitis, Budd-Chiari, and Wilson disease count, even with pre-existing liver disease. 3. 80% is drugs and toxins, and acetaminophen alone is over 40%. 4. Grade the encephalopathy. Grade 3 means intubate. 5. N-Acetylcysteine helps, even when acetaminophen is not the cause. 6. Non-acetaminophen failure carries about 70% mortality. These are the sources behind today's teaching. The American Association for the Study of Liver Diseases position paper on acute liver failure. The European Association guidelines on fulminant liver failure. The Lancet reviews. The original King's College paper from 1989. And the analysis of N-Acetylcysteine in non-paracetamol liver failure. Thank you for watching. Verify everything here against your own institutional protocols before applying it at the bedside.